most people in the room know me. I'm the director of a children's charity called Tumaini la Maisha here in Tanzania. I also am on staff in Muhimbili as a pediatric oncologist. So we have a reasonably sized NGO, which started with about 3 of us, up to about 30 now. And we have clinical and non-clinical and fundraisers and all manner of people who are dedicated their entire day to looking after children with cancer and trying to raise funds and awareness for kids' cancer in Tanzania. I'm also the chair of the Magic Teapot, which is my favorite title, which is the Tanzanian Pediatric Oncology Team. And we have lots of the team members here today. But basically, anyone who's interested in children's cancer is part of that team. So obviously, first and foremost, the government of Tanzania and all of the health institutions in this country, all of my colleagues here in the room, and lots of local NGOs and international NGOs and health and education facilities. And we're all holding hands together to try and sort out children's cancer. So this is a talk, sorry, this is a talk I give somewhere else. So this is basically me coming to Tanzania, and the decision brought great joy amongst my friends and family at the time. And at that time, they were basically saying, why cancer, you know, with all the other things that are going on? But we all in this room know why. So what do we know? As we all know, in the 1950s, if you couldn't cut it out, you died. And now, because in large part to the generosity of the clinicians at the time of sharing information and being brave and taking very major steps that weren't ever taken before, we now have 85% cure around the world. And there's no reason why that can't happen here. Why children's cancer as a priority for the government, because this is something that we're selling to the government tomorrow, hopefully. And it is because if you support children's cancer, you have to have a functioning health system. Referral patterns, procurement, and all of the specialist and subspecialist services have to work if we're going to cure children's cancer. And I'm sure you could say the same in the adult world. It's also personal to me, having had breast cancer twice and sitting here surviving it, or standing here surviving it, a little confused sometimes. I had a disease that was really quite hard to treat the second time around, and I seem to have beaten it, which is great, but there's then no reason, and it's really shameful that there's any child dying of very curable diseases, and we just have to make that change. So, as we all know, it's started in Ocean Road. We had one centre, one doctor, one condition, which was Burkitt's lymphoma, was the first place that there was drugs, and we had 3 nurses. But there was strong political will, which was really, really important. But at that time, in 2005, the disease-free survival 3 months in 2006 was 12%. That's not the overall survival, that is the survival 3 months at the end of treatment. So that means that basically probably less than 5% of children were surviving in that context, except for children with Burkitt's lymphoma who are separate, and those children actually did considerably better because they were being concentrated on. So 70% were surviving in Burkitt's, but every other condition, less than 5%. They were only seeing about 107 children in the year, and we would have predicted at that point that there was 2,500 to 3,000 children in the country getting cancer every year. So really the survival was essentially 0. And this is a child who I always talk about because she highlights the issues at the time. She died of a Burkitt's leukemia, which is a really difficult disease, which you all know about, to treat. But the manner in which she died was really inappropriate, in that there were no nurses looking after her the night she died. There was no way of giving her pain relief or fluids or to stop her vomiting. So she marked a line in the sand that no other child was going to die in the manner that Mariam did. That was clearly how we felt at the time when this happened. This was the Ocean Road facility at the time. It was a 17-bedded unit. And when we started, because there were very little in the way of drugs, there were 17 beds and 17 children. But as we started to think about how to change this and make things better, we started to see a change. So the first things we did were the free things. So we started doing ward rounds, we started acting on temperatures, we started making sure children got blood transfusions when they needed them. But then we quickly realized if you don't have the drugs, that the children are not going to get better. And at the time, there was only drugs for Burkitt's lymphoma. So we basically made a decision that all children's cancer drugs were also free of charge, and we just figured a way. So we didn't have any money, but that didn't stop us. We also needed help with our diagnostics, and very luckily we have very strong support from a hospital in Dublin, and they do all of the immunohistochemistry pathology and have done for the last 10 years for us. They do occasionally get a surprising package. So this is what happened as we started making cancer care free in Ocean Road. We went from one child per bed in 17 beds to, on our busiest day, 90 children in 17 beds, 90 children in 17 beds. So it was really untenable. We did have a situation where there were kids, lots and lots of kids getting treatment on the same bed, which is obviously better than not getting treatment, but it's certainly, it could be better. So we made a decision that that needed to change. And what we have decided, and this is the exciting thing that is happening now, is we have decided that we want to reach every child in Tanzania. And we're doing this with a hub and spoke approach. So there's a 4-tier system from quaternary, tertiary, secondary, and primary level. Primary level do not treat, they just suspect and stabilize and transfer. Second level, they choose, or we choose together, how many conditions that they feel comfortable treating, and otherwise they use our services in tertiary and quaternary level, Centre for Pathology, and for procurement of chemo and other items. Tertiary levels are all the university hospitals across the country, and they obviously should be able to treat almost everything unless there's a subspecialty issue that needs referral to the quaternary centre. And they would then in turn supervise the second level and the primary level facilities. And the quaternary level, which is in Muhimbili/Ocean Road, depending on what the condition is, it basically does all of the pooled procurement, at the moment is driving the pathology, but obviously as pathology comes on board for at least the tertiary level centres, that will change over time. And in that way, no matter where the child walks into in Tanzania, they will get the same level of care or be transferred to a site rapidly where they can get that care. So the hub is, as I said, Muhimbili. We have a children's cancer ward with it's sort of expandable. I never know how many beds we have. It's between 50 and about 65 beds. I don't know what happened to the walls melt or something. And when we moved them, this is how the children felt, going from 90 children to 17 beds to 65 plus 22 beds in our hostel. So it was obviously a lot better. With our clinical service, we have obviously doctors and nurses and pharmacists. So all of our chemotherapy is reconstituted by pharmacists. We have centralized procurement, both of chemotherapy, of the high-tech antibiotics, GCSF, and special needles that are needed for diagnostic and staging purposes. At the moment, all flow and immunohistochemistry is offered free of charge to any child in the country by just sending the specimen. You don't actually have to send the child. Then of the subspecialty things like neurosurgery, cardiac surgery, I know renal dialysis is coming on board across the country, but it's also available in Muhimbili. And then hopefully in the very near future, in the next 6 months, we'll have a pediatric intensive care unit. Obviously, anyone who's in pediatrics has been involved in the development of the national pediatric guidelines and protocols for pediatric cancer, and I think this is an enormous step forward, and really congratulate the government for the initiative to drive this forward, so that again it's ensuring that if a centre is going to treat children's cancer, they have to read from the same book. We have a tumour board every week, and I think it's extremely valuable, and it's something that we would be certainly recommending with all the tertiary level centres. This is just an example of the types of ward services that we have. So we have a fume hood for chemotherapy, and we would hopefully, as Tumaini la Maisha, be able to provide a fume hood to both tertiary and second level centres over the next, hopefully, year or two, so that everybody has the same standards of safety for their staff as well. Ward-based procedures. Because we do most of our bone marrows, lumbar punctures, biopsies, that kind of thing on the ward level, and we also stain and look at them under the microscope ourselves for bone marrow at least, and for cytospins, it actually speeds up the service and how fast we can make diagnosis. That's Dr. Lighty there looking at a bone marrow or a lumbar puncture for us. As I said, the pathology service in Dublin has been enormous support to us, and just to highlight why. So basically, they see any sample that needs immunohistochemistry, and there wasn't immunohistochemistry until very, very recently in Dar es Salaam. And if there isn't immunohistochemistry, then it really makes some of the tumours very difficult to diagnose, and often the pathologists, not through any fault of their own, have to guess almost. They can only say small round blue cells, and by the clinical picture, they can make an assessment of what it is. We did look at, so there were 20 samples over a 3-month period which had a report both from Ireland and from Tanzania, and only 11 of those, the results matched, and the discordance was quite marked. It wasn't just diffuse large B versus Burkitt's, it was Burkitt's versus Rhabdo. So it was really, really important. It highlighted to us the real need and urgency to get immunohistochemistry in the country. And that, I'm really happy, is happening this year and in more than one site. So that's going to be a huge improvement, and we can bring things back that were outsourced before. The service improvements in hematology have been fantastic. Yeah, we have flow cytometry in Wimbili, and we do hope that all the tertiary level centres will also develop flow cytometry. By the end of the year, we'll also have, using flow, we'll have minimal residual disease assessment for leukemia patients. And again, that's a huge improvement. So our training, we have lots of formal training. We have a master's program, which we do need to kickstart again for the doctors. We also have a 10-week course in pediatric oncology nursing, which is going to start in August. We're starting it in Dar es Salaam, then we hope it'll be run every 6 months, once in Dar es Salaam, once outside, somewhere else in the country. We hope the next one will be in KCMC. And we've lots of travellers, so lots of the specialists have gone to Ireland or elsewhere overseas to get some on-the-spot training. We're also creating a database which will be offered free of charge to all of the participating centres. And we have lots and lots of psychosocial support that, again, we would like to help the centres develop over the time as they work with us, both in terms of tertiary level centres all having hostels and schools and play facilities. Second level centres may not need all of those, but they still need some psychosocial support. And these are just more of the pictures of the children enjoying themselves. Exercise obviously is one of the important things. Then the spokes are, we have, as I say, tertiary level centres, which are the university hospitals. We have second level centres, which are any centre really that wants to participate and has the facility to give even basic chemotherapy. And then primary level centres are those who will just suspect, stabilise and transfer. We use the mobile money and DHL, which are hugely helpful to us. So they transport specimens and chemotherapy and needles and things throughout the country and also overseas. And if a centre has a child who they want to send to us, then we can either M-Pesa them the money or the ticket. We can buy the ticket for them through the mobile phone technology, and that works really well. We also use the mobile phone technology to do weekly meetings with our sister and our partner organisations to discuss all of their patients, so that even if they don't have an oncologist on site, they have access to an oncology opinion day and night with a weekly scheduled call, and that really, really helps. So quickly the results, sorry. So basically what's interesting in this slide is on the right there you'll see that 50% of the diagnosis were lymphomas back in 2005. That may have been something to do with the fact that the only treatment available in 2005 was for Burkitt's lymphoma, hence it was largely the one that you would plumb for if there was any chance this is what the child had. In 2017 it's much more like what you would expect, except for perhaps that the number of brain tumours is really quite small. But leukemias, lymphomas and retinoblastomas are high on the agenda, with Wilms tumor also very important. Our results were creeping towards 50%, and I think we're over 50% survival now. And at our sister sites, KCMC is the one we want to talk about because it's been running for about 22 months. And in the first 6 months of running it, 30% of the patients that were seen in KCMC absconded, with survival rates of 15%, which are pretty dismal, and we were all very depressed. But a year later, the survival has raised from 15 to 50%, and over 100 children have been treated. So this is doable. The other things that we're doing is lots of things with Burkitt's, lots of things with Wilms. I won't go into it because I can see them waving at me. What's special about this is it's free. Across the country, we want everything to be free. The government is pitching in, obviously, with bringing this the national health insurance card, making it compulsory. That will definitely help. Tumaini La Maisha as a charity are committed to providing all the chemotherapy and all of the things that we provide in Wimbili across the country. We would like to merge all of the kind of different groups that are helping, including iCare and including FCCT and TTCF, to one group so that we can actually have our own kind of branding that everybody will recognize. It's also, just the last thing to say is that it is affordable. So if we say in 2016 there were 500 children and 320,000 euros was spent on their chemo and the nurses and doctors that look after them by TLM, and the same equivalent by Muimbili, we did the cost analysis, so it cost about 640,000 to look after a child. So that's the cost, if you double that, including the Muimbili cost, that's 6 kids in Europe with ALL. So that's really something that we should be able to afford. And that is most of what I want to say. So that's it. We want to get to every child. And with your help, we will.